define?
Rise in blood.
Okay, rising in blood pressure. Any other?
Rise in blood volume.
Okay, good. Okay, so the outline of the session for today, at the end of the session, you should be able to define what is hypertension, and you should be able to know the etiology and the epidemiology of hypertension, and you should be able to know about the pathogenesis of hypertension, and then finally, the clinical manifestation, investigation, and diagnosis of hypertension. Those are actually very important. But most importantly, as a clinical pharmacy professional or the pharmacy professional in general, you need to know how we are going to manage hypertension and what treatment modalities we are having in the management of this most common cardiovascular disorder. So hypertension is defined as persistently elevated arterial blood pressure. So most of the time, in order to come up with a diagnosis of hypertension, we need to have actually at least 2 or more elevated reading on blood pressure, at least 2 visits or over a period of 1 to several weeks. So that if you encounter like an elevated in blood pressure within a single measurement, you can't say the patient is actually having hypertension. There are actually various causes of elevating hypertension. Some people is actually become very panic and the blood pressure can be elevated during the time of visit. Because of this reason, the standard definition or diagnosis to come up with hypertension, a patient should have a minimum of 2 or more elevated reading on at least 2 visits in the span of 1 to several weeks. That is very important. Then apart from that, when we say hypertension, the blood pressure can be, we do have systolic blood pressure, we can be diastolic blood pressure. So either of them can be elevated or both of them can be elevated. But in most cases, in hypertensive individual, both systolic and diastolic pressures are usually elevated. Okay, so when you say hypertension, the blood pressure should be above 140 to 90. So the highest value is usually the systolic blood pressure. The lower value, that is the denominator, is usually the diastolic blood pressure. So if the blood pressure of an individual is above 140 over 90, the span of 2 visits and more than 2 readings, we can say the patient is actually having high blood pressure or hypertension. Okay, then apart from that, most of the patients, when they're having hypertension, they are usually asymptomatic. Because of this reason, hypertension is known as a silent killer until the patient is having organ damage. So most of the time, or most clinicians, or most internists normally diagnose hypertension after the patient is having end organ damage. So it is one of the most significant risk factor for cardiovascular diseases. So the end organ damage is actually very, very serious. It can cause a stroke, can cause heart failure, can cause renal damage, it can cause renal eye problem, it can even cause blindness. So because of this reason, adequate monitoring or adequate control of blood pressure is very essential. Okay, then when you look at the international classification of blood pressure, when you say normal, the BP, the systolic should be less than 120 and the diastolic should be less than 180, sorry, 80. Then prehypertension. So when someone is actually having prehypertension, most of the time we don't initiate any drug treatment. So most of the time we just normally like treat with lifestyle modification. So if the blood pressure is actually between 120 to 139, that is systolic, or if the diastolic is between 80 to 89, you can say the patient is having prehypertension. So in such scenario, we don't initiate any pharmacological treatment. So pharmacological treatment will be initiated only when someone is having stage 1 Okay, by the way, make sure you join the same ID and password when it expires. Huh? Okay, so hypertension stage 1 is between 140 to 159, or the diastolic is between 90 to 99. So stage 2 is above 160 and the diastolic is above 100. So this is actually the classification of hypertension. So remember, monotherapy is usually recommended when a patient is actually having stage 1 hypertension, but stage 2 hypertension, most of the time, combination therapy is usually recommended. Then remember about the staging of hypertension or classification of hypertension. If there is a disparity in category between systolic and diastolic pressure, the higher value determines the stage. For example, if the systolic is actually 160, or maybe if the systolic is 145, and if the diastolic is 110, so there is, have you seen the disparity in the stage of hypertension? Have you seen the disparity? 145 systolic, but the diastolic is 100. So if there is a disparity in the stage, the highest category will define the stage of the disease. So in this condition, 145 seems stage 1, but the diastolic is in stage 2. So the stage of the hypertension will be the highest category. So you have to know the difference. Huh? Okay, so this is how we categorize hypertension. Then, when you look at the epidemiology of hypertension, hypertension is actually widely prevalent and significant contributor of cardiovascular related morbidity and mortality. And even hospitalization cost and treatment cost is not very easy, especially if the patient is actually cannot afford. Then when you look at the global epidemiology of hypertension, 51% of all strokers and 45% of ischemic heart disease are actually because of hypertension. You can actually imagine 51% of all strokes are actually, and 45% of all ischemic heart diseases are caused by hypertension. So you can see the most common complications of hypertension is actually it can lead to a stroke. Most commonly, hemorrhagic stroke is very common as a result of uncontrolled blood pressure. Then remember, hypertension is actually very common as we age. So as we age, the blood vessels are very stiff, and there is actually a pressure build up within the blood vessels. Remember, when you say hypertension, is a pressure within the blood vessels. As a result, because of aging, as we age, the blood vessels are actually very stiff, and we are having many cardiovascular problems. So the probability of getting hypertension is very, very high. Unless the patient is actually having secondary causes, the probability of getting hypertension in adult age or in younger population, like less than 60 years old, is very, very minimal. But this time around, because of lifestyle condition, the probability of actually even diagnosing hypertension at the age of 30, at the age of 20s are actually very common. But if you notice hypertension at the age of 20s, you have to actually find out secondary causes, because most of the hypertension that occur at the age of 20s are usually because of secondary condition. We'll discuss later. So when you look at the epidemiology in terms of men and female, the percentage in men is very high before the age of 55, especially in female. Estrogen is actually protective. So estrogen is actually, the level of estrogen is normal before menopause. So before menopause, the risk of hypertension is very high in female as compared to men. So, but after the menopause, the prevalence is actually very common. Even it is actually very high in female after menopause, especially after the age of 65. So please note the age of disparities. Like before menopause, the probability is very minimal in female. but because of estrogen is actually protective, and it is actually having vasodilator activities. Okay, then let me take you through about mechanism of regulation of blood pressure. So maybe let me pause and ask one question, maybe one of you. So how does blood pressure is regulated in the body system? How does blood pressure can be regulated in the body system? Any volunteer? Amina, can you try? How does blood pressure regulated in the body system? Anyone who can try? Okay, maybe it is a first class, but maybe in the future, make sure you have to read before the session. Then when you look at the regulation of blood pressure, there are two principal regulations in the body pressure. The first one is usually for short-term blood pressure. So most of the time, the sympathetic nervous system is the one that regulates the blood pressure in short-term manner. For example, if someone is actually very panic, because of environmental stimuli, the BP can be elevated. This elevation is mainly due to activation of the sympathetic nervous system. Yes, those are very important for immediate or short-term regulation of blood pressure because of various factors. But however, in the long run, the principal hormone or the principal system that regulates blood pressure is usually the renin-angiotensin-aldosterone system. So remember, when you think about cardiovascular disorders, don't forget about the RAS system. You can't miss anywhere in the world. If you discuss about cardiovascular condition, RAS system, especially in terms of hypertension, in terms of heart failure issues, RAS system is actually very, very important to regulate blood pressure. So long-term control of BP is usually based on renin-angiotensin-aldosterone system. So before we discuss in detail about the management of hypertension, we are going to discuss about the mechanism of regulation. Okay, then the next slide is about the baroreceptor and sympathetic nerve system. As I mentioned before, baroreceptor is a special receptor that can detect a change in the blood pressure within the blood vessels. So when there is a change in the blood pressure, there is actually a sensor that is known as a baroreceptor that can actually sense blood pressure. And then this is very important. So baroreflex involves sympathetic nerve system that are responsible for rapid and moment-to-moment regulation of blood pressure. So most of the time, these receptors are very sensitive when there is a change in the blood pressure. So maybe the next slide will give you actually a brief summary how blood pressure can be regulated when there is a sudden increase or a sudden decrease in the blood pressure. But remember, baroreceptor, when there is a fall in the blood pressure, you can say a fall in blood pressure, maybe if there is a significant loss of blood because of trauma. When there is a significant loss of blood pressure because of maybe trauma or blood loss, we can say the blood pressure is actually low. So in that condition, the baroreceptor is usually inhibited. So when the baroreceptor is actually inhibited, it actually decreases impulse to the brain. Then this decreased impulse to the brain normally decreases parasympathetic activity and increases sympathetic activity. So generally speaking, when parasympathetic activity is decreased, there is actually increased sympathetic activity. Okay, then what will happen when the sodium level is actually reduced, or when the sodium level is actually reduced in the distal renal tubule, then it can even release, stimulate the release of insulin. As I mentioned before, catecholamine increase or release in catecholamine level, that is sympathetic stimulation, can increase the release of renin. So in such a way, it can actually activate the sympathetic nerve system and ultimately increases what? Increases the blood pressure. Then, as I mentioned before, renin is an enzyme which is originated in the kidney but catalyzes the conversion of angiotensinogen from the liver to angiotensin 1 in the blood. So this angiotensin 1 can be converted to angiotensin 2 by angiotensin converting enzyme. So remember, this angiotensin converting enzyme is actually one of the most common drug targets in the management of hypertension. So these converting enzymes are usually targeted. Then what will happen now? We do have what? Angiotensin 2. So this angiotensin 2 binds with angiotensin type 1 receptor. It binds with angiotensin 1 receptor. Then it can actually elicit its physiological effect. So what will happen? Angiotensin 2 by itself is it is actually vasoconstrictor, so that it can constrict the blood vessels and increase the blood pressure by increasing total peripheral resistance. Then angiotensin 2 can actually activate the release of aldosterone from the adrenal cortex, so that it can cause sodium and water retention. So in such a way, when you increase, when you look at the effect of angiotensin 2 on the blood pressure, it has special effect. That means it can cause vasoconstriction and increase total peripheral resistance, then ultimately increases blood pressure. And as a result, angiotensin 2 activates the synthesis of aldosterone. Remember, aldosterone is synthesized in the kidney from the adrenal cortex. So this adrenal cortex, aldosterone is very important for sodium and water reabsorption. So when sodium and water is reabsorbed, what will happen? Blood volume will be increased, then cardiac output will be increased. So when cardiac output is increased, what will happen? There is an increase in blood pressure. Remember, blood pressure is a product of total peripheral resistance and cardiac output. So any endogenous factor or any physiological change that can actually increase the blood volume or cardiac output and the total peripheral resistance can directly or proportionally increase the blood pressure in the body system. So remember, this is the most common regulatory system in the body system. So it is mandatory to know what is the angiotensin system and what physiological changes we are expecting when someone is actually, when the RAS system is activated. So remember, as we age, the RAS system will be activated because the blood vessels are actually stiffened. And as we actually age, the RAS system can be activated because the patient is actually having any other cardiovascular disorder that can activate the renin-angiotensin system. So in summary, as you can see this diagram, there is renin from the kidney. There is renin in the kidney that can be secreted by because of various factors, as I mentioned before, like maybe loss of blood, maybe reduced perfusion in case of heart problem, maybe in case of change in electrolyte level. Then this activates the conversion of angiotensinogen from the liver. Remember, angiotensinogen is originated from the liver, then converted to angiotensin 1. So this angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. So this converting enzyme is very important to convert angiotensin 2. So remember, angiotensin 2, once it is produced, it has actually diverse physiological effects. One, it can actually increase contractility of the heart and increases cardiac output. Then, secondly, angiotensin 2 can actually contract smooth muscle. So as a result, it causes vasoconstriction and increases total peripheral resistance. By increasing total peripheral resistance, it can increase the blood pressure. Then apart from that, angiotensin 2 in the brain, it can actually increase the release of vasopressin, that is antidiuretic hormone, that can actually increase the blood volume by increasing water reabsorption. Then in the kidney, as I mentioned before, specifically from the adrenal cortex of the kidney, it can actually increase the release of aldosterone. So aldosterone can increase sodium and water reabsorption, and this ultimately increase blood volume. Then by increasing the blood volume, it can actually increase total peripheral resistance or cardiac output in such a way it can increase the blood pressure. So this is the regulation, how body is actually regulating blood pressure in the body system. But remember, if there is this regulation or excessive activity of the RAS system, the patient can encounter high blood pressure. So the current pharmacological agents we're having in the market, some of them, like the latest medication we're having is the renin inhibitor that can actually inhibit renin, unwanted or undesired activation of renin. Then the most commonly drug available in the market and most commonly used clinically is the converting enzyme inhibitor. Like those, can someone give me an example of ACE inhibitors for angiotensin converting enzyme inhibitor? Anyone?
Captopril.
Captopril.
Anyone?
Captopril.
Sinopril.
And Lapril.
I can't hear.
Captopril.
Captopril, yes.
Fosinopril.
Sorry?
Fosinopril.
Okay, good. The captopril is the short-acting one, but the enalapril ones are actually the long-acting one that can be taken once a day or twice per day. Okay, good. So if you see a suffix pril at the end, means those are ACE inhibitors. Then
So we can't.
we do have also a drug. Can you hear?
No.
Then apart from that, we do have a drug. We do have a drug which actually inhibits angiotensin receptor antagonist. Those certain families are angiotensin antagonists, so that they can actually prevent the binding of angiotensin to its receptor. So this is how these pathophysiological mechanisms are actually a drug target in the pathogenesis of in the pathogenesis of hypertension. So I don't know how many. Can we see this short video, like 3 minutes video, or you can see on your own time? What do you think? Can you see this short video? Sorry?
We can watch it.
Okay, fine. Huh? I think to save your bundle, maybe the videos you can actually watch it. But it is good normally if we watch it at the moment so that for a clear understanding. Yeah? But anyways, do you have any question about the RAS system, the renin, angiotensin, aldosterone system? Any question? Any question? If I ask someone briefly explain the renin, angiotensin, aldosterone system, are you all of you can actually briefly explain the RAS system? Let me pick one. Favan?
What the renin-angiotensin system does, the angiotensin increases the BP, which has pressor effects, which cause direct vasoconstriction and increased catecholamine release and increased sympathetic nervous system activity. And it also has volume effects, which stimulate aldosterone, and this makes sodium and water reabsorption.
Okay, thank you. Fine. Then let me proceed to the next session. So I thought normally all of you have actually captured this idea. Then apart from that, by the way, we do have neuronal regulation of the blood pressure. Those are not very important mechanisms. The most important mechanisms are actually the reward system, the baroreceptor, and sympathetic nervous system. But anyways, some blood pressure can be regulated by neuronal regulatory system. We call it presynaptic and postsynaptic regulation. So, okay, have you covered about the sympathetic nervous system in physiology? Have you covered about it? What is the role of alpha 2 receptor when it is activated? What is the role when it is activated? Can someone give me what will happen when alpha 2 receptor is activated?
There will be a fight or flight response.
When alpha 2 receptor is activated? Any other? What will happen? By then, we do have drugs which is actually targeting alpha 2 receptor. Most of the CNS acting antihypertensive agents like the clonidine, metaldopa, they are actually targeting alpha 2 receptor. Anyone?
So don't they inhibit the don't they inhibit the sympathetic system?
Okay. Yes, how does they inhibit the sympathetic nervous system? You are right in the right track.
Yeah. I just know that they inhibit the sympathetic nervous system and therefore they reduce the blood pressure.
Exactly. So the alpha 2 receptor, we call them autoreceptors. Remember, Hermes will take you through about, when you start maybe the nervous pharmacology, he will take you through about how neurotransmitter is actually synthesized in the body system. But then when we say autoreceptor, they actually pick the neurotransmitter at the site of function. We call it the postsynaptic is actually the site of function of the neurotransmitter. So it will take or increase to the presynaptic neuron. So those autoreceptors normally take away the neurotransmitter from the site of action. Despite they are actually an agonist, the effect is usually negative. So by increasing the uptake of neurotransmitter, they can actually stimulate the inhibition of norepinephrine release. So they inhibit the release of neurotransmitter in such a way they can actually reduce blood pressure. So the drug we are using in the market for a second line in the management of hypertension, which is known as clonidine. Clonidine is actually targeting alpha 2 receptor. By activating alpha 2 receptor, it reduces sympathetic outflow in such a way it can actually reduce blood pressure. Remember, when sympathetic outflow is reduced, it can actually, blood pressure can be reduced. Then the postsynaptic level, the stimulation of postsynaptic alpha 1 receptor. Remember, when alpha 1 receptor is activated, it has actually significant vasoconstrictor effect. So when the blood vessels are actually constricted significantly, it can increase total peripheral resistance. As a result, blood pressure can be increased. So currently, even we do have drugs which is actually targeting alpha-1 receptor. We call it alpha-1 receptor blocker, like the prazosin. I hope you have covered somewhere. I don't know, maybe in medicinal chemistry. Okay. The second neuronal regulation of the blood pressure is actually activation of the beta-1 receptor. There is actually beta-1 receptor in the heart. So it can actually cause what? It can actually cause contractility of the heart. Then, but activation of beta-2 receptor mostly causes vasodilation. So the effect on the blood pressure is usually vasodilation. So those are some of the neuronal regulation of the blood pressure. Then apart from that, we do have vascular endothelial mechanism in regulating blood pressure. So those vascular mechanism, when there is deficiency of local synthesis of vasodilating hormone, like the prostacyclin, the bradykinin, they can actually cause increase in blood pressure. When there is excessive production of vasoconstricting substances like angiotensin 2 and endothelial, they are very important cause of essential hypertension. We'll discuss later what is essential hypertension, but for the time being, we'll say essential hypertension is a blood pressure which is a high blood pressure without any known causes. We call it essential hypertension, or the causes are usually unknown. Then nitric oxide deficiency. Nitric oxide is actually very most common endogenous vasodilator. They are very important for vasodilation. So remember, when there is inadequate vasodilation, what will happen? There is a high possibility of increase in the blood pressure. Now, this is all about regulation of blood pressure. Regulation of blood pressure. And now, let me take you through about the pathogenesis. Let me take you through about the etiology of hypertension. What really causes high blood pressure? Most importantly, in adult population, like at the age of 30, at the age of 20, that is something unique. That is something unique and not familiar. Okay. Then, the most common, based on the etiologies, hypertension can be classified into two categories. Primary, that is known as essential hypertension. So that is, the etiology is not known, and more than 90% of the cause of hypertension are not known. So majority of the hypertension in the clinical setup is usually unknown. So the causes are usually multifactorial, and there is actually the role of genetic component. That is why primary hypertension can be actually inherited from the parents to the children. So the probability of having hypertension, by the way, if you do have family history of hypertension, the probability of getting hypertension is actually very high, especially if your parent is actually having essential hypertension. So assuming you are actually in the hospital setup and actually clerking a patient with hypertension, so when you are actually assessing the patient, you need to find out normally what really causes hypertension. So in the family history, you have to check whether the patient is actually having family history of hypertension or not, which is actually very, very important. So this form of hypertension cannot be cured, but it can be controlled. Yes, most cases of essential hypertension, the probability of cure is very unlikely, but secondary, it can be cured, but mostly if the underlying causes are actually treated. But the primary essential hypertension cannot be cured, but it can be controlled. Then when you look at the secondary causes, those are actually like the least common type of hypertension, and they do have known causes. Some of them, they are actually caused by drugs. Some of them are actually caused by secondary conditions, such as chronic kidney disease. Remember, CKD is the most common secondary cause of hypertension. If you know someone who is actually having chronic kidney problem, the probability of actually having hypertension once in a time is very, very high, because kidney is the principal organ that controls the blood pressure. Okay, and even fluid and electrolyte balance. Then the first cause, which is very rare, is pheochromocytoma. Pheochromocytoma we'll discuss in the fall semester when you are discussing about endocrine disorders. Is one of the most common, very rare type of tumor in the renal medulla. So remember, okay, what is the time right now? Okay, we do have actually like 10 minutes. I don't know whether we can end the session here from here today or not, but make sure write your name and ID number. Yeah, write your name and ID number. So what is pheochromocytoma? Anyone? Pheochromocytoma?
Tumor of the adrenal medulla.
Okay, so what will happen when there is a tumor in the renal medulla?
You can't release renin. You can't release renin.
So what will happen if you can't release renin?
You can't activate the RAS system.
But we have said pheochromocytoma. By the way, there are different sites for the release of renin. The juxtaglomerular cells are the one that can actually release the renin. But renal medulla is mainly involved in the production of catecholamines, yes? Yeah, so when someone is actually having a renal medulla or tumor in the renal medulla, means they excessively generate what? Catecholamines. Mostly norepinephrine level will be significantly elevated. So what will happen when catecholamines are excessively produced in the body system? There is activation of what? Sympathetic nerve system that can actually cause what? Hypertension. That is why when someone is actually having this problem, when someone is actually having pheochromocytoma, the probability of hypertension is very, very high. I think I have seen like one case of pheochromocytoma, but by the way, this is very rare. Then most of even the treatment is usually surgery. They resect the tumor, then after that, the BP will come back normal. But most of them, they develop hypertension because of excessive production of catecholamine. Then glucocorticoids. Have you covered maybe somewhere glucocorticoids? How does excessive use of glucocorticoids causes hypertension? How does it cause? Anyone who can try?
Water reabsorption, it goes hand in hand with sodium reabsorption. So
Okay.
when sodium is reabsorbed, a lot of sodium is reabsorbed, a lot of potassium is excreted, and it's one of the contributors to blood pressure. It's one of the contributors to something.
Okay, good. What is the principal role of glucocorticoids? Glucocorticoids are very important in sugar control. They can actually increase the blood sugar level. The gluco stands from carbohydrates, so they are actually increase the level of glucocorticoids. But most importantly, those glucocorticoids, they do have actually different physiological effects. They do have different physiological effects. We'll discuss in the next semester. But mostly, those glucocorticoids, they do have also mineralocorticoid effect. That means they can cause what? sodium and water reabsorption. In such a way, when someone is actually taking excessive glucocorticoids, the probability of actually getting hypertension is very high. So remember, this one is mostly when someone is having autoimmune condition and using long-term glucocorticoids, the probability of hypertension is actually very high. But remember, when someone is taking glucocorticoids, you have to monitor the blood sugar level because it can cause hyperglycemia. Okay, then Cushing syndrome, still we are going to discuss in the next semester, but still Cushing syndrome is one cause of secondary hypertension. So what do you know about Cushing syndrome? Anyone? What is Cushing syndrome?
Excess glucocorticoid production.
Yes, when you say Cushing syndrome is just any condition that increases the level of cortisol, we call it Cushing. So when cortisol level is very high, the probability of getting hypertension is very high because of mineralocorticoid effect. But remember, when you say mineralocorticoid effect means they do have aldosterone-like effect. Okay, good. Then, Kirne, we have seen lastly, the primary aldosteronism. There is a condition known as primary aldosteronism that is characterized by excessive secretion of aldosterone in the adrenal gland. So remember, adrenal gland is located on the top of the kidneys. So when there is overproduction of aldosterone, there is increased sodium and water retention that can actually cause what? Hypertension. So those are the most common secondary causes. But sometimes even drugs actually can cause even hypertension. Like those stimulants, remember those amphetamine, even the mirror, they can actually release catecholamine in the long run. It can increase even blood pressure. We have seen corticosteroids, decongestants. Most of the decongestants are vasoconstrictor. Is there anyone who has taken decongestants? Maybe if someone you have like nasal congestion, anyone who has taken phenylephrine or pseudoephedrine decongestants, which is applied topically? Some of them, they can be absorbed systemically and they can actually cause even vasoconstrictor effect because of the effect on alpha-1 receptor. Then pharmacognosy, have you covered about ergot alkaloids? Ergot alkaloids?
No.
Okay, ergot alkaloids, bromocriptine is available locally. Yes, it is available by the locally. Mostly it is actually a dopamine agonist. So ergot alkaloids are vasoconstrictor and they can actually increase blood pressure. Then do you know about erythropoietin stimulating agent or erythropoietin?
Yes.
Yeah, erythropoietin is actually the most commonly used drug in the management of anemia in CKD patient. However, the problem with erythropoietin, by the way, if you have questions, most likely we have like 2 minutes and maybe you need to join.
Hello, Big Daddy, come kiss me. You wanna
What?
kiss me? Big Daddy. Big Daddy. Bell.
Okay.
Bella.
Can you mute your
Hello.
microphone or I mute? Okay, let me mute Mwandi, the one who is causing the noise. Okay, then erythropoietin is actually one of the most commonly used drugs in the management of anemia in CKD patient. But the problem with erythropoietin, it can actually cause hypertension. So the moment the patient is actually taking erythropoietin, you have to even measure the blood pressure. There are various mechanisms how erythropoietin actually causes hypertension. Maybe you can go and read, then you tell me about the possible mechanism how erythropoietin can actually increase the blood pressure. Then lastly, erythropoietin can actually increase viscosity of the blood. Do you know that? Erythropoietin,
Yeah.
If the hemoglobin level is actually above 10, you have to stop taking erythropoietin, even in shaky patient. Otherwise, they will develop what? They will develop. What will happen when the hemoglobin level is actually keep on increasing? I hope all of you are actually actively listening. Yeah? For sure, if you don't attend the session, you cannot do the test. So make sure you are actively listening. Yeah? Despite we don't see each other. What is the risk of keep on increasing, or what is the risk of excessive increase in the hemoglobin level? Anyone who can try?
I'm not sure, but if you keep on increasing it, the viscosity increases. So there might be clots.
Exactly, yes. If you see like a hemoglobin level of like 20, that means okay. So today we are still discussing about the continuation of hypertension. So today we will discuss more the pathogenesis as well as the treatment modalities of hypertension. As I mentioned in the previous session about the regulatory mechanism of blood pressure, mostly the RAS system and the sympathetic systems are actually very important, as I mentioned in the previous session. So if there is actually a malfunctioning of either the RAS or abnormal neuronal mechanism or defect in the peripheral autoregulation, it can actually increase the risk of having hypertension. So no one factor is solely responsible for essential hypertension. It is just a multifactorial, as I mentioned in the previous session. So the potential mechanism for the pathogenesis is actually any parameter that can increase cardiac output, like vasoconstriction, increase in the blood volume, excessive stimulation of the RAS system. Those factors are actually increase cardiac output. As we have seen in the previous session, blood pressure is a product of cardiac output and total peripheral resistance. So any factor that can increase cardiac output can actually increase the risk of hypertension. Then the secondly, increased peripheral resistance. It could be actually excessive stimulation of the RAS system, then even sympathetic activation, endothelial derived factors, some of the vasoconstrictor endothelial derived factors, they can actually increase the risk of hypertension. Then, as we have seen in the previous lesson, blood pressure, the systolic and diastolic blood pressure. I hope you know what is systolic blood pressure. It is actually pressure that is exerted on the blood vessel when there is a cardiac contraction. So, like during systole, when the left ventricle is actually contracted, it will eject blood to different organs. So at this point, the pressure exerted on the blood vessels during left ventricle contraction is known as systolic blood pressure. So usually the pressure is actually very high as compared to diastolic blood pressure. Then next, diastolic blood pressure is usually achieved after contraction. Now, after contraction of the left ventricle, now the left ventricle will be actually relaxed in order to fill adequate amount of blood. That condition is known as diastolic blood pressure or diastole. So the pressure exerted on the blood vessels when the heart chambers are relaxed, it is known as diastolic blood pressure. So those systole and diastole, it is known as like cardiac cycle. So in one cardiac cycle, systole and diastole can actually occur. Yes, contraction after feeling, now contraction will take over so that all other organs can actually get blood. Then there is one condition known as mean arterial blood pressure. So this mean arterial blood pressure is just an average pressure throughout the cardiac cycle of the contraction. So most of the time, this mean arterial blood pressure is very important in the management of emergency. We'll discuss normally hypertensive emergencies toward the end. So basically, when we're managing hypertensive emergency, we're mostly using the mean arterial blood pressure. So remember, during a cardiac cycle, like 2/3 of the time is spent in the diastole. So the feeling time usually take longer, but the contraction will take like 1/3 of the total cardiac cycle. So when you are calculating the mean arterial blood pressure, it is usually calculated 1/3 of systolic plus the 2/3 of diastolic blood pressure. So this is, so remember, these mean arterial pressures are not commonly calculated, but it is very essential, especially in the management of hypertensive emergencies, because we're titrating the drug based on the mean arterial pressure. So we'll discuss at the end. Then I mentioned about the arterial blood pressure is a product of cardiac output and total peripheral resistance. Then in the pathogenesis, remember about the role of natriuretic hormone. So these natriuretic hormones are endogenous hormones that have the potential to inhibit sodium potassium methylase and actually interfere the transport of sodium, and it's actually very important to eliminate sodium in the body system. Remember, when we do have high level of sodium in the body system, these natriuretic hormones are very essential to eliminate the remaining amount of, or the excessive amount of sodium from the body system through kidney. So if there is actually inherited defect in the kidney's ability to eliminate sodium as a result of maybe a defect in the natriuretic hormone, the probability of having high blood pressure is very, very high. So we can say natriuretic hormone can actually increase, they can actually lower blood volume, but this hormone is usually activated when someone is actually having high blood volume, when the blood pressure is actually very high, this will be activated. Then apart from that, as I mentioned in the previous lesson, in the regulatory mechanism, blood pressure can be regulated by vascular endothelial mechanism. So these vascular endothelial mechanisms are actually like vasoconstrictor and vasodilating substances. So if there is an imbalance between the two, this is actually results in hypertension, like deficiency of vasodilating and excess activity of vasoconstricting substances. They can actually lead to essential hypertension. Then sometimes the patient, they can have intrinsic deficiency of nitric oxide, which is very important for vasodilation. So those are actually intrinsic vasodilator. They are very essential for vasodilation and reducing blood pressure. So those are some of the pathogenesis of hypertension. So as a result, if there is imbalance of those endogenous regulatory mechanisms, the patient can develop hypertension. Then if there is an electrolyte disturbances, epidemiological and clinical data suggests when there is excess sodium intake, the probability of getting hypertension is very high. That is why as a lifestyle modification, as much as possible, we need to reduce salt consumption. Yes, that is a general recommendation. Then maybe let me take you through how we measure the blood pressure. So appropriate techniques in measuring BP is very vital in the diagnosis and in the management. That is very essential. So in principle, if you are actually in a position to measure blood pressure of a patient, you need to actually take certain precaution to get adequate result. Firstly, then you need to instruct the patient to avoid exercise, alcohol, caffeine, nicotine consumption like 30 minutes before a BP measurement. Otherwise, it will actually mislead the result. Because if you actually measure the BP after exercise, for sure the patient can be hypertensive because of exercise. So as a result of this, those things should be avoided like 30 minutes before you measure. Then apart from that, the patient should actually comfortably sit at the back, supported, and the arm, as you remember in the lab, you need to avoid constrictive clauses, especially in the brachial artery, because they can actually interfere with the blood pressure. So they have to sit and relax, and the arm should be supported with actually with the seat. That is the recommendation. Okay. So legs should not be crossed and feet should be flat on the floor for a minimum of 5 minutes before the first reading. That is very important. So to reduce deviation in the BP measurement, the patient and the clinician should not talk during the BP reading. It is very important, otherwise you will actually mislead the result. Then what will happen after you put everything on the brachial artery? You have to put your stethoscope as you have. Oh, the stethoscope you haven't seen. Okay, anyways, you just assume. So after the patient cuff is inflated above the systolic blood pressure, the pressure indicator should be dropped at, so the knob will actually open slowly at the rate of 2 to 3 millimeter mercury per second. That is the recommendation. Then remember, the stethoscope should be placed so that you can actually hear on the brachial artery. I hope you know where it is, which is actually in the antecubital foci, like a bit 1 centimeter above the antecubital foci. That is the location of brachial artery. So after that, when you actually slowly open the indicator, when you actually slowly open the knob of the blood pressure apparatus, now you are actually slowly dropping the BP. So the first audible sound is noted as systolic, and the last audible sound is known as diastolic blood pressure, respectively. So this is actually the most accurate measuring. It is the most accurate way of measuring blood pressure. But the manual one, the digital one, is actually there is a possibility of an error, and accurate measurement might not be achieved. But nowadays, most of the clinicians, they are using the digital blood pressure apparatus. Okay. Then, as I mentioned before, a minimum of 2 readings should be recommended in the span of like 1 minute interval. That is the general recommendation. But when you look at the practicability of this measurement, it is very not commonly done. They just do one single measurement, they continue. So in principle, if there is a measurement varies like more than by 5 millimeter mercury between the 2 readings, then 1 or 2 additional BP measurements should be collected and multiple readings should be averaged. So this should be actually indicated in principle so that you can actually get accurate results. Okay. Then classification should be based on the average reading. That is the most common important recommendation. So having said this much, let me take you through about some of the clinical presentation of hypertension. So as I mentioned at the introductory session in the previous class, most of hypertensive patients, they don't have any clinical presentation. So most of them are actually even asymptomatic. Okay, so most of them in the clinical manifestation, they just look at it, the blood pressure measurement. That is why in every facility, this time round, when you go anywhere in the nursing triage stage, most of the time they will take the vital sign first before you see the physician. So the first clinical manifestation, because they are asymptomatic, So most of the patients, they don't complain any clinical manifestation unless there is an organ damage. So they usually rely on the sign that is actually the blood pressure measurement. Then another clinical manifestation is actually hypertension related complications and other clinical manifestation. So you will see the patient become unconscious and maybe one side of the bodies are actually weak and maybe paralysis, and even like they will actually even become unconscious then when they develop stroke. Then transient ischemic attack, it is actually a type of a stroke, but the duration is actually less than 24 hours duration. Okay, then retinopathy, they can actually even develop visual problem. They can say, my vision is actually blurred, so I cannot see properly. Then after that, maybe they develop even heart problem, maybe heart failure, angina pectoris, even myocardial infarction. So those are some of the complications. You will see even problem in the kidney. So they are complaining pain in the kidney areas, or either left or right kidneys or both kidneys. So they will actually feel pain in that areas of the kidney. So otherwise, you can't really see any clinical presentation when someone is actually having hypertension. Okay, diagnostic consideration. Diagnostic consideration is made usually after multiple measurement. So average, and there must be at least 2 and above measurement, and in the span of like 1 week or to several weeks time. So there should be a repeated measurement at least 2 times in the span of 1 week and above. Yes, in order to conclude the patient is actually having high blood pressure. Then apart from that, other lab tests that should be done, despite they are not directly related to high blood pressure. If someone is actually having hypertension, and because hypertension is actually multifactorial cardiovascular condition, you have to actually look at many parameters like the lipid profile. Then you have to look at even the hemoglobin, hemoglobin A1C, and even the blood sugar level. I hope you have covered about those laboratory parameters in the previous semester with Jonathan. Maybe let me hear your feedback about what is hemoglobin A1C. What is hemoglobin A1C? The first person at that day, what is hemoglobin A1C, and what is the importance?
Hemoglobin has something to do with telling the amount of blood.
Hemoglobin A1C. Remember, yes, it is hemoglobin A1C. I don't know whether you have covered in clinical chemistry, but for sure you must have to. Okay, Amina? Amina, can you hear? Okay, Angela?
I think the hemoglobin A1C is related to the blood sugar levels collected over a period of time.
Okay. So maybe can you elaborate more? Yes, I agree. It will actually indicate the blood sugar level. So this like the previous blood sugar level. For example, if I want to know normally your blood sugar level, what is happening today? Is it right to use hemoglobin A1C test?
Right now, I know what they use is the one for fasting glucose. Like if you go to the hospital, they tell you not to eat in the morning and then it is taken. That's the one I know that happens nowadays.
Okay, how many types of blood sugar tests do you know?
I know the one for fasting and the random one.
And the other one is
Yes.
the third one?
I've forgotten. I don't remember.
The other one is the hemoglobin A1C.
Oh, okay.
Yeah, fasting,
Okay.
random, and hemoglobin A1C. So hemoglobin A1C, it is also known as glycated hemoglobin. But this hemoglobin, remember, when the sugar level is actually very high, it binds with sugar. That is why it becomes glycated hemoglobin. So the lab technologies, they will measure the glycated hemoglobin, but glycated hemoglobin will tell us the sugar control level in the span of 3 months. It will tell you normally how was the blood sugar level in the past 3 months. Huh? But if you want to see the blood sugar level for today, you have to go either random or fasting blood sugar level. Okay, so most of the time, glycated hemoglobins are very important to measure the blood sugar level in the past. Yes. Okay. So it does not need to be fasting. So because of the correlation between hypertension and DM, when someone is actually having DM, even you have to check the blood sugar level, either fasting, then either fasting, glycated hemoglobin, or random blood sugar level. And please note about the normal values. So when you say the blood sugar level is actually impaired, if it is between 5.6 to 6.9 millimole per liter. So remember, like most of the facilities in Kenya, they measure the blood sugar level in a millimole. So you need to actually familiar with this unit of measurement. Then, if the hemoglobin level, if the fasting, the blood sugar level is actually above above 7 millimole, we can say the patient is actually having a diabetes, or the sugar level is actually very high, but it should be in line with the clinical features of DM. Okay, but remember hemoglobin A1C, if the level is actually above 6.5%, it is actually, it will tell you the patient is actually having diabetes. So that is why we are going to do those parameters. Okay. Then remember, when someone is actually hypertension, because hypertension can cause renal damage, you need to check even renal function test. So how do we assess renal function test? Maybe let me ask some other person. Anita?
You check for the electrolytes.
How do we assess?
You check for the electrolytes in the urine and proteins.
I don't know. I cannot hear. I don't know about your connection.
I'm saying you check for the electrolytes and proteins in the urine. You do a urine test.
Anita, can you speak?
I'm speaking.
Here, I don't know. Maybe there is some problem with my computer. Maybe can you repeat?
I was saying, I'm not sure. You do a urine test to check for electrolytes and proteins.
Okay, which electrolyte are we supposed to check?
Sodium, potassium, chloride.
So will it suggest, so how does it suggest normally someone is having kidney problem by checking the sodium level in the urine?
I'm not sure there.
Okay, for sure you have covered renal function test, how to assess renal function test in the previous semester. Okay, then okay, Annette. Annette, you do have background noise, huh?
I don't think so. Okay, let me.
For sure, you have opened maybe your phone, and yeah, I think there must be an electronic device nearby you.
Yeah, let me sort it out.
Okay, maybe.
Yeah, is it okay now?
Okay, yes, now it is okay.
Okay. What was the question?
So, how do you assess renal function test? Now, like assuming you are complaining renal problem. So, yes. So, like you are complaining pain in the lumbar region. Yes, we can hear. We are thinking normally you are complaining pain in the lumbar region. Annette, you can't hear? Okay. Maybe let me go to other person. Patel.
Hi, sir.
Yes, how are you?
Good, you?
Okay, I'm good. How do you assess renal function test? Assuming you do have a patient, you are suspecting normally, I need to check like the kidney function test of an individual for that patient. So how do you assess?
You can do electrolytes, urea,
Urea and creatinine. Any other?
The albumin tests.
Albumin test. Albumin, is it in the serum or in the urine? Is it in the serum or in the urine sample? Which sample?
Urine.
Okay, why?
I'm not sure.
Okay, let me go to Heaven. Heaven?
Yes, sir.
Okay, how do you assess renal function test of an individual?
You check the creatinine and urea and the urea and electrolyte levels.
Okay, so why we are actually measuring creatinine level to assess the kidney function test?
Creatinine usually measures, like, it can tell about the clearance of urine, so it can tell if the kidneys are working well.
Okay, good. So remember, creatinine is actually a metabolic products of muscle metabolic products like such as myoglobin. So this creatinine is usually excreted by the kidney. So if the kidney is actually functioning very well, you don't see actually significant amount of creatinine in the serum. So you measure the serum creatinine level. If it is elevated, it will give us normally there is acute damage maybe in the kidney. Then other parameter is normally albumin level in the urine. Remember, normally protein will not pass the glomerulus. Glomerulus is just like a filter, like a mesh. So if there is no damage in the glomerulus of the kidney, there is nowhere normally for protein to be filtered in that system. So because of that reason, if there is actually damage in the glomerulus of the kidney now, protein will actually leak and you will see normally protein in the urine. We call it microalbuminuria. So microalbuminuria is defined as the measure of like 30 to 300 milligram per gram creatinine. So if you see, this is actually a ratio. If you see actually the protein level between 30 to 300, this is known as microalbuminuria. If the albumin level is actually above 300 milligram in the urine sample, we can say it is macroalbuminuria. So there is actually a significant loss of protein in the urine. So, but sometimes even we can use albumin to creatinine ratio in a spot of urine sample is actually becoming very common nowadays. So you look at the albumin creatinine ratio. If the ratio is actually very high, it will tell you there is actually significant damage in the kidney. That means albumin to creatine ratio. That means if there is if the ratio is very high, means there is significant loss of protein in the urine. That is albumin, which is actually indicator of kidney damage. So those are some of the tests we can actually assess the renal function test using a lab parameter. But we can even use blood urea nitrogen. But those are actually the most important tests to assess renal function test. I think this is all about the general overview of hypertension. Yes, hypertension. Then now, let us actually spend a bit of longer time discussing about the management of hypertension. How do we manage hypertension? Okay, good. I hope most of you have seen a patient with hypertension, yes, in your lifetime. I'm expecting, because this is actually one of the most prevalent cardiovascular condition in the world, as well as in Kenya. So when you look at the goal of therapy, the short-term goal is actually we reduce blood pressure. That is actually our goal of therapy, especially when someone is having excessive elevation in the blood pressure. The long-term goal, we need to reduce mortality due to hypertension-induced complications such as stroke, congestive heart failure, even kidney damage, even erythropathy, and ultimately even blindness. So those are the goals of therapy. Okay, now, before I go to detail about the management of hypertension, maybe can we spend a few minutes to brainstorm like what you know about the management of hypertension. Faiz? Faiz, can you hear? Okay, Geoffrey? Geoffrey, can you hear? Okay, Joyce?
It's a summary of everything.
Yes, give us normally how we manage hypertension. No summary of everything. How do we manage hypertension?
Management.
Yes. Yeah? If you see a patient with hypertension, how do you manage? Yes, that was the question. The moment. So weight loss is recommended. So your body mass index should be within the normal values. I hope you know how to calculate body mass index. So if it is between 18.5 to 24.9 kg per meter square, that is actually the recommended normal weight of the patient. So we call it, this is healthy. So if you are actually overweight, think about your weight so that you don't get hypertension or any other cardiovascular problem. Then secondly, from non-pharmacological therapy, a DASH type of dietary pattern is recommended. DASH stands for, maybe can someone tell me what is DASH diet? Maybe some of you might even be using before. What is DASH diet? What is DASH diet? Can someone tell me? Maybe I pick or name. Laura, what is DASH diet?
Eating foods that have low sodium.
Okay, eating foods that have low sodium. Any other?
Fruits, vegetables, and oats.
Okay, good. Fine. So when you say DASH diet, it is known as DASH diet by this stands for dietary approach to stop hypertension. So you apply normally dietary approach to reduce hypertension. So in principle, when someone is actually applying that diet, they are supposed to consume a diet rich in fruit, vegetables, low-fat dairy products with reduced content of saturated and total fat. So that is the general principle of DASH diet, and they are very healthy diet in reducing hypertension. Okay, next is about reduced salt intake. Most of you have mentioned about the risk of sodium, excessive intake of sodium. So generally speaking, according to different international guidelines, the recommendation is actually 1 teaspoon of table salt per day is sufficient enough, so that to prevent, especially in those patients who have hypertension, that is the recommendation. Then physical activity. I hope physical activity is actually very important, especially if they do have hypertension. So like 3 to 4 sessions per week is recommended. Then alcohol consumption. Remember, alcohol is actually even one cause of hypertension. So you reduce alcohol consumption to reduce the risk of hypertension. So this table is actually to show you about the role of lifestyle modification in the possibility of actually reducing the approximate possible value to reduce blood pressure. If you see even weight reduction, if you reduce your weight, you can actually even reduce 5 to 10 millimeter mercury of your blood pressure at 10 kg. If you adopt that diet, you can actually even see 8 to 14 millimeter mercury can be reduced. If you see dietary sodium restriction, you can actually reduce 2 to 8 millimeter mercury. Yeah? So even without taking any pharmacological molecule, you can actually even see how much lifestyle modification is actually very important to reduce, to control blood pressure. So it is good to advise even our grandparents about this issue. Then, when you look at the management algorithm of hypertension, remember what guides you in treatment of choice is actually the patient condition and the stage of hypertension. So, if the patient is actually having no compelling indication and stage one, it requires usually monotherapy. So from monotherapy, maybe we can use ACE inhibitors, ARBs, calcium channel blockers, and even diuretics. Oh, if so, in case if monotherapy is not effective, maybe we can use 2 combination therapy. Combination therapy of 2 drugs is actually can be used. Then, if someone is actually having stage 2 hypertension, as we have seen in the classification, we can actually initiate with combination therapy, ACE inhibitors or ARBs with calcium channel blockers, or ACE inhibitors or ARBs with thiazide diuretics are actually recommended. For compelling indication, that means if someone is actually having hypertension with any other comorbid condition, you can actually use. I'm going to know later toward the end of this session, so that we'll discuss more how we're actually treating when someone is having other comorbidities. So when you look at the pharmacological therapy of antihypertensive medication, the first choice, according to even GNC guidelines, are the diuretics, beta blockers, ACE inhibitors, and calcium channel blockers. If you see, even those drugs, if you see those drugs or most of the patients, they are actually either on diuretics, There are also NAC inhibitors or calcium channel blockers or combination therapy. They cannot actually pass from these unless they develop resistance. Then, in case of resistance, the second line treatments are actually vasodilators, alpha-1 blockers, alpha-2 sympathomimetics, and even direct vasodilators. So let me take you through about diuretics. So those diuretics are actually, they can increase urine outflow. So they actually promoting like removal of fluid in the body system in the form of urine. So most of them, as a result of this, they remove sodium and water from the body system. So if sodium and water is removed in the body system, means you are reducing the blood volume, then you are reducing what? The blood pressure. So they can be used as a first-line drug therapy for hypertension. Yeah, they can be used as a first-line therapy for hypertension, unless there is a compelling reason to choose another agent. So especially the thiazide type of diuretics are the first-line drug in the management of majority of hypertension patients, unless any contraindication. So those are the classes of diuretics: the carbonic anhydrase inhibitors, the thiazide diuretics, and loop diuretics, and even potassium-sparing diuretics. Are we together? Okay. So I don't know whether you have covered, maybe, I think you have covered in the last semester about diuretics. Maybe can you give me one example of thiazide diuretics? Vitalis? Vitalis?
Hello?
Yes, we can hear. Yes, yes.
Okay, chlorothiazide. That's one example.
Any other?
As well as, okay, in dopamine.
Okay, yes. Any other?
Hydrochlorothiazide.
Yes. Hydrochlorothiazide.
Yes. That's all I can remember.
Okay, good. At least you have actually mentioned the most common types of diuretics, and which is good. So, as I said before, I'm not going in detail because you are going to discuss in detail about the pharmacology, but I'm actually focusing on. Let me focus on. Just a minute. I will focus on about the doses and some pharmacokinetics and dynamic property of the drug is that even I'm focusing on about how one agent is actually better than from other agents. So for the pharmacology, you can actually liaise with the pharmacologist. Okay. Then this is actually the summary. This is actually the summary of the action, the site of action of diuretics. So thiazide diuretics, they are actually acting in the distal renal tubule, but carbonic anhydrase inhibitor, they are actually acting in the proximal renal tubule. The loop diuretics are actually in ascending loop of renal. So this is actually the place, or this is the renal tubule, which majority of sodium and water absorption is actually carried out. Because of this reason, loop diuretics are actually known as high ceiling diuretics because they are very effective to actually even to cause diuresis, to reduce blood volume. So remember, when you are actually blocking reabsorption of sodium in ascending loop of renal, like some part or a small amount of sodium and water can be reabsorbed in the distal renal tubule, but it can also be absorbed even the collecting duct. But they are not very significant. Actually, they cannot significantly absorb what has been actually blocked in the ascending loop of renal. That is why loop diuretics are actually the most effective type of diuretics, and were most commonly used when, in case of emergency, when someone is actually having significant edema, and to achieve immediate effect, we have to use loop diuretics because they are actually very important to reduce the blood volume. Then the carbonic anhydrase inhibitors, most of the time they inhibit carbonic anhydrase enzyme, which is actually important for absorption of sodium and bicarbonate in the proximal renal tubule. So if you inhibit this one, you can actually, so this time around, the use of carbonic anhydrase enzyme inhibitors are very minimal in the management of hypertension. They are very minimum and they are actually very weak diuretics. Because of this reason, they are not actually commonly used in the control of hypertension. So they do have other indication. That one we'll discuss later. Okay, so most often, and they can be actually given orally once or 4 times daily. Most of them, they block the reabsorption of sodium and bicarbonate. That is the principal mechanism. Then this time around, the most common role of diuretics are actually usually the management of glaucoma. They can actually block the production of alkaloid production in glaucoma. I think we'll discuss later in detail when we reach normally condition that affect the eye in the next, not in the next semester, in the last semester, I think. In the last semester, you will discuss about drugs and the management of eye disorders. Okay, anyways, acetazolamide, they can be useful in treatment of glaucoma. That is one role. And unless and otherwise, for hypertension treatment, effect is actually very minimal and not commonly used. Then, when you look at the adverse effect of acetazolamide, remember acetazolamide, they promote bicarbonate excretion. Because of that reason, the risk of metabolic acidosis is actually very high, but it is usually very mild. It's very mild, but it can cause acidosis because bicarbonates are actually eliminated from the body system. Then it can cause potassium depletion and renal stone formation. Those are some of the adverse effects. But most importantly, I will spend a bit of time to discuss about thiazide diuretics because those are actually the most commonly used diuretics in majority of our hypertension patients. So from thiazide diuretics, we do have chlorthalidone, hydrochlorothiazide, indapamide is also available. Metolazone is also available, but it is actually the most potent type of thiazide diuretics. Even you can see 2.5 to 5 milligrams per day is actually sufficient to control high blood pressure. But what is most commonly used is actually thiazide diuretics. So most of the patients, they're actually on 25 milligrams daily dose of thiazide diuretics. Maybe let me ask one question. Let me pick someone randomly. Okay. If someone is taking thiazide diuretics, when is the best time to administer? Let me see someone toward the end. Which diuretics are very effective? Tony. Tony?
Hello, sir. Yes, sir.
Okay. When is the best time to administer diuretics?
I think early in the morning, early in the day. In the morning.
Hmm. Why?
Early in the day. Because it causes urination mostly. Yeah, I think so.
Okay.
Or it can interrupt the sleeping pattern. Yeah, that's all I know.
Okay, good. So, in principle, a diuretic should be administered in the morning hours so that it does not disturb the sleep pattern of the patient. Otherwise, because of frequent urination, he's supposed to actually frequently visit the washroom. Because of this reason, when you advise the patient with diuretics medication, the treatment sheet, you need to counsel properly. The best time, if it is only once per day, the best time to administer is actually in the morning hours. Okay, then thiazide diuretics, as I mentioned before, hydrochlorothiazide is actually very common. It is actually blocking the reabsorption of salt the distal renal tubule. By the way, if you this renal tubule, you have to know. It is actually mandatory to know. So you can't miss any question about those loop of renal, where is the site of action of diabetes, even in pharmacology, even in the board exam, even in physiology. So it is actually mandatory to give much emphasis about this loop of renal when you are actually discussing about diuretics. So mostly they block the reabsorption of sodium and chloride. This is actually mainly in the distal renal tubule. They are the most suitable diuretics for long-standing hypertension, and they are actually sulfonamide derivatives. I hope Yashoda has covered very well these areas. Because they are sulfonamide derivatives, some people even develop allergic reaction. Yes, if someone is actually having allergic reaction for sulfur drugs, is to be very cautious when you initiate the diuretics because of the possibility of actually allergic reaction. So some patients they can actually develop allergic reaction. Okay, then I have mentioned about the doses, and hydrochlorothiazides are actually the most commonly used diuretics. Okay, they are very effective orally, so it can be given orally, and we will see the effect usually within the span of 1 to 3 weeks to produce a stable reduction. So we might not see immediate effect, but to see the full effect, we have to wait the patient. We have to wait until 3 weeks of treatment. But because they are secreted by organic acid secretory system, there is a probability of a combination for expression in the, with acidic drugs. So we have to be very careful. I hope you have also covered about the thiazide-like diuretics. So from thiazide-like diuretics, the compound they lack thiazide structure, but they do have similar mechanism of action. They do have similar mechanism of action. That is why they are actually thiazide-like analogs. So from these, metolazone is actually the most potent type of diuretics, and it is actually like 5 milligram is sufficient enough. Even when someone is actually having advanced renal failure, we can use metolazone, because even in advanced renal failure, it can actually effectively remove sodium and water from the body system. Okay, so this is what I want to spend a few time about thiazide diuretics. So when you look at treatment-wise, it is actually the most common treatment in hypertension as well as heart failure patients. In heart failure, the effect is actually very minimal and not commonly used, but we'll discuss in detail later when we are reaching about heart failure. But mostly, when you think about diuretics, think about hypertension, because that is where you can see the significant role of this class of drugs. Then, when creatinine clearance is actually less than 30 ml per minute, now this is like advanced stage of chronic renal failure. If the creatinine clearance is actually very low, we can say the patient's renal function is actually significantly compromised. So, despite we give thiazide diuretics, the efficacy is actually very, very limited. In such a scenario, we don't give thiazide diuretics as a class of drug, as the drug of choice, because the efficacy is actually very limited. Remember, it is about like 25%. It is about like 25% of sodium and chloride reabsorption, not 25%. Around 10% of the sodium and chloride reabsorption is actually carried out in the distal renal tubule. So, if the kidney is actually significantly compromised, there is still significant reabsorption in the ascending loop of in the ascending loop of renal. So the efficacy is really very limited. In such a scenario, you have to consider loop diuretics. Okay, so when you look at the adverse effect of thiazide diuretics, what is the most common challenge for thiazide diuretics is they can cause hypokalemia because they promote the elimination of potassium in the body system. Then they inhibit the release of insulin. Remember, when insulin release is actually inhibited, the probability of hyperglycemia is actually very high. As a result, it can cause precipitation of diabetes. So you can actually look at it. If someone is actually having maybe diabetic or high sugar level, this might not be a drug of choice because of the risk of hyperglycemia. Then hyperlipidemia, it can actually increase the risk of LDL cholesterol. I hope you know about the risk of LDL cholesterol. What is the risk? Joyce? Joyce, can you hear? Okay, what is the risk of, what is LDL cholesterol?
Low.
Okay, any other?
It's the low density lipoprotein, which is the bad protein in the body. It's the bad cholesterol.
The bad, why it is called bad cholesterol?
Because it occupies the blood vessels.
Okay, good, yes. It's actually very bad cholesterol because it actually transports cholesterol from the liver to the blood vessels, and it causes actually accumulation or deposition of cholesterol in the blood vessels. It can actually even cause atherosclerosis by hardening and stiffening or buildup of plaque of cholesterol in the blood vessels. Okay, good. So thiazide diuretics, they can actually increase the risk of hyperlipidemia. Then they can even cause hyperuricemia because they inhibit the excretion of urate. Remember, okay, what is the risk of hyperuricemia? Noor said? Noor, can you hear?
Yes.
Okay, what is the risk of hyperuricemia?
Gout. Someone can get gout because of uric acid crystals can form.
Okay, good, yes. Yeah, so if someone is actually having gouty arthritis, and if you are supposed to initiate thiazide diuretics, for sure you are actually worsening the condition. So that is why when you are actually reading something, you have to look at actually everything in totality. So for if someone is actually having arthritis, gouty arthritis, because uric acid accumulation, especially around the joint, the form of monosodium crystal, they can actually cause inflammatory reaction and causes gouty attack and even joint damage. As a result, it can actually exacerbate the situation. So because of this reason, if someone is having this problem and if they are using thiazide diuretics, we need to be actually vigilant at the pharmacy to intervene this kind of prescription. Then hyponatremia, it's OBS because they inhibit sodium and water reabsorption, as I mentioned before. Then hypercalcemia. Hypercalcemia, it actually inhibits the secretion of calcium, then can actually even elevate the calcium level in the blood. So when someone is actually having, when someone is actually taking thiazide diuretics, it is good to be very vigilant. The possibility of actually even occurring hypercalcemia. which is actually very, very important point to consider. So those are some of the thiazide adverse effect of thiazide diuretics. So in summary, thiazide diuretics are actually one of the most common class of drugs as a first-line drug in the management of hypertension. So they are acting the distal renal tubule. They block sodium and chloride reabsorption in the distal renal tubule. As a result, they reduce the sodium and water or the water volume in the body system. And dose-wise should be given early in the morning, so we can give up to 25 milligram per day. Okay, the next class of drug from diuretics, which is most commonly used, is actually loop or high ceiling diuretics. They are called high ceiling by the way because they do have a potential, or they do have a significant potential to reduce the blood volume. That is why they are called high ceiling diuretics, because more sodium and chloride reabsorption is occurred in the ascending loop of renal. Then by inhibiting the co-transport of sodium, potassium, and chloride, they are actually very effective to reduce the blood volume. So from loop diuretics, furosemide is actually the most commonly used. Torsemide is also available, but not commonly used. It's very important. Bumetanide is also available. It's a clinic acid I have never seen, but because of ototoxicity, it is not actually a commonly used drug in the market. So most likely in your practice area, the most common drugs you will encounter is actually loop diuretics. The brand name is Lasix, Lasix. Lasix is the most common drug. We can use like 20 to 80 milligram. It can be even above that dose, but the oral dose is actually mostly between those, unless the patient is actually having a problem. So I mentioned about the mechanism of action. Furosemide is the most commonly used drug. The loop diuretics they can actually even increase prostaglandin synthesis. Yeah, because of the effect on prostaglandin synthesis, any drug that interferes with the prostaglandin synthesis can interfere with the side effect of loop diuretics. Please take a note of that. Yes, if you give them Lasix with NSAID, for sure, you can actually even reduce the side effect of the drug, the effect of loop diuretics. So this is actually contraindication. Okay, then loop diuretics, as I mentioned before, it is actually the most commonly used drug when someone is actually having edematous condition. I hope you have covered cirrhosis. Huh? Yes, have you covered about alcoholic liver disease or liver cirrhosis? I think let me spend few time. Okay, Radit. Radit, can you hear? Okay. Riha?
Yes, sir. I know liver cirrhosis is the inflammation of the liver that can be caused by alcohol consumption.
Okay, good. Yes, this actually it is actually changing of the liver normal tissue to fibrotic tissue. Okay, that is liver cirrhosis. Then what is the role of loop diuretics in the management of liver cirrhosis? What is the role? Can someone try? Sorry. Can someone try? Samiha?
Yes, sir.
Okay, can you state normally what is the role of loop diuretics in the management of liver cirrhosis?
Okay, when someone has liver cirrhosis, there is accumulation of fluids. So the loop diuretics helps with removal of the excess fluid body.
Okay, exactly, yes. Remember, when someone is actually having liver problem, ascites is actually one of the complications when someone is actually having advanced stage of liver disease. So in such a scenario, we need to actually initiate we need to initiate loop diuretics so that you relieve edema, yes, because of ascites. But apart from that, loop diuretics are actually commonly considered even in acute pulmonary edema of heart failure. That is actually the most common used drug. But we'll discuss in heart failure management, loop diuretics are actually the most commonly used drug in the management of heart failure to reduce actually pulmonary edema or fluid accumulation. But as I mentioned before, when someone is actually having edema, as a result of complications of hypertension, we can still use loop diuretics, but it is not a primary drug unless thiazide diuretics are not very effective to control the blood pressure. Okay, good. Then, in contrast to thiazide diuretics, loop diuretics can actually excrete calcium in the body system. Because of this reason, it is useful in the treatment of hypercalcemia. So, when someone is actually having hypercalcemia, we can even use loop diuretics in the management. I think those electrolyte imbalances we'll discuss in the presentation. How do we manage electrolyte imbalances like high calcium level, high potassium level? I think one group will actually do a presentation in this area. Okay. Yes, that is very important point to note. Then loop diuretics are useful in the treatment of hyperkalemia because they actually even promote elimination of potassium. Yes, yeah, with the exception of torsemide, which is actually having a longer half-life, loop diuretics should be administered twice daily versus once when utilized primarily for their antihypertensive versus diuretics effect. So most of the time, they are usually given twice daily dose. Okay. Then, what are the adverse effects of loop diuretics? When someone is taking furosemide Lasix, which is the most commonly drug, what ADRs are we supposed to monitor at the pharmacies when they're actually visiting the pharmacy, maybe during the follow-up visit? So remember, loop diuretics, they do have a potential to accumulate in the ear, like aminoglycosides. Then they can actually increase the risk of ototoxicity. Yes, that is one complication. Then they can actually even cause hyperuricemia, like thiazide diuretics. They can actually even cause hypokalemia and even hypomagnesemia. Then excessive diuresis can lead to hyponatremia and even hypotension, which is very common. That is why when you give this class of drugs, we need to monitor the patient properly. Otherwise, we can actually even kill the patient because of hypotension and electrolyte imbalances. Yeah, that is very key information to note. So at least when you are thinking about